Good morning, everybody. On behalf of Ekklesia Park, welcome to our second webinar on the topic of dementia. During the first webinar, Dr. Susan Kutzer gave a very insightful description of the condition, the risk factors, the medication. You are welcome to get the link on our website in order to listen to her very insightful talk that she gave. Today we're going to talk about the managing and caring for the patient with dementia. And we are very fortunate to have very knowledgeable, experienced and educated nursing professionals to do the presentation. First of all, Emmy Jackson, who has got her Beaker degree and specialized in psychiatry, community health and administration. She has vast experience in the psychiatric training, developing elderly care programs, and opened a private practice in April 2017, providing and facilitating psychiatric elderly care and palliative care services, and specializing in care coordination for people with a form of dementia and brain diseases. So Connect to Care provides specialized assessment and care to persons and their family members who requires assessment, assistance, guidance, health counseling, support and or home care. Our second speaker is Janet Allman, who specialized in intensive care and psychiatry. She started working with patients with dementia in 2014, and in 2018 she joined Sister Emmy Jackson and the memory care team following the high demand for quality community nursing services. She's passionate about cognitive assessments and stimulation appropriate to the stages of cognitive impairment. I would just like to say that afterwards everybody is welcome to ask some questions, which Sister Esme and Janet will be answering. So over to you, Sister Esme. Emmy.
Thank you very much, Minda, for the opportunity. This is a topic that obviously we can talk about for a long time. There's a growing need in the community, and Janet and myself as nursing sisters have had the privilege of working with the geriatricians like Dr. Kutzer, as well as the psychogeriatrician, Dr. Ryan Fuller, who practices from the Ekklesia clinic in Parktown and in Alberton, treating specifically patients with dementia, the elderly patients, and having specialized in the field as well. So as I said, we're privileged to have been able to work with him and his team for the past couple of years and being able to specialize in this field. So I'm going to share my screen with you to just tell you and give you some pointers in how we can manage and care for patients with dementia. I think sadly, often Janet and I see in the community that there perhaps is an approach of, well, put your loved one in the corner and allow them to die. And that for us, it saddens us very much because there's a lot that can be done for a person with dementia or cognitive impairment and related conditions. And I'm going to recap a little bit on what Dr. Kutzer shared with us last week, just to tie up with the suggestions and the comments and the recommendations and the knowledge that we're going to share with you regarding treating the elderly person with cognitive impairment and or dementia. So I've got a couple of interesting pictures that I just want to show you, and you'll see the first one obviously is up on your screen.
We can't see your screen. Sorry, Amy, we can't see.
You can't see the screen, sorry. Sorry about that. Share screen. Sorry about that. My sincere apology. Just get it to. Okay, is that better? Can you see the screen?
Yes, thank you.
Okay, so I'm just going to step back quickly. As I said, we will share with you some knowledge about the managing and the caring for patients with dementia. Let me just, that's the first picture we want to share with you. I hope that it evokes interesting and emotional thoughts and feelings with you. And I'd like you to share any of these feelings and thoughts that you are experiencing right now in the chat, please. This is another one. This is a similar picture. And I'm obviously not sure whether you've seen some of these pictures before. And just one more. And these pictures were taken by an American photographer who is very passionate about elderly care. And yeah, did these particular pictures. And of course, it relates to the topic that we're talking about. And the question is raised, what are we seeing when we look at these pictures? So the chap that did it's called Reflections by Tom Hussey. And just to tie up and recap some of what Dr. Kutzer shared with us last week, there's an increase in the number of people in the world that suffers from dementia and that is diagnosed with this condition. And one of the studies said that worldwide there's about 7.7 million new cases per year, which will mean that every 4.1 seconds a new case is diagnosed. And I'm sure you will find that as startling as I do. It's frightening to think that this is how many people there are in the world and around us that suffers from this condition. So if we want to say, how do we care for people with this particular problem? Is this a daunting task? And where would we start? What would be important? For me, the important thing is that, and I think Dr. Kutzer's presentation also highlighted how important it is that one gets a correct diagnosis. For example, that she mentioned, if a person has got hydrocephalus, the hydrocephalus condition, which is similar to the dementia conditions, but in fact is reversible. Wouldn't you want to know if your loved one or your patient perhaps has a condition that is reversible, as opposed to, my apology that I went too quickly on my clicking there. But of course, Dr. Kutzer highlighted for us the different kind of conditions that there is in terms of your dementias. And again, I think it is important to just highlight to say that it is so important that we understand what is dementia, what is Alzheimer's. Is it the same? Is it different? We often, if we get referrals, people will say to us, my loved one has got dementia or Alzheimer's. And of course, as Dr. Kutzer demonstrated and taught us, the difference is that Alzheimer's is actually a form of dementia. And of course, there's all the other forms of dementia, like your vascular types, like Parkinson's, that can eventually turn into a dementia, and of course, vascular dementias and the frontotemporal dementia, previously called Pick's disease. When I train and I explain to people what is dementia, I explain to them the fact that it is about your brain that is failing. And when your heart is failing, you can have different kinds of conditions because your heart has different structures, and different structures of the heart, of course, can fail. And it's the same with your dementia. Different parts of the brain start to fail, and therefore there are different types of dementias, and that, of course, presents the different symptoms or signs that we see in different patients. Because of course, no two patients presents exactly the same with the same conditions or with the same symptoms. So if we start talking about how do we treat patients with cognitive impairment or dementia, or how do we try and prevent the condition, again, some of what Dr. Kutzer pointed out. A couple of things are very important. So as I pointed out on the slide, the aim is to provide quality of life for the patient, for the families, and or the caregivers, because of course the caregivers can be the family, or it can be other trained persons, untrained persons, untrained caregivers perhaps, that work with the patient on a daily basis. And it's important that we assist and support them and assist them to find some quality of life. A care plan that is based on the patient's need, of course, is crucial. It has to be a structured and daily routine that requires that we provide some stimulation activities for the patient. Their pre-morbid personality and their hobbies, their likes and their dislikes has to come into play. It doesn't help if we suggest certain activities and the person previously hated doing, for example, exercise, or they didn't actually like reading even, they never liked watching TV, they don't like to play particular games, or they never did a Sudoku. So again, one has to take that into consideration when we provide the care plan and we build the care plan. Prevention of social isolation, again, is crucial. We often see in our work in the community with many patients that we visit and that we assess, we find that they've become isolated over time as their cognition has deteriorated, and this lack of social stimulation. And again, also as Dr. Kutzer pointed out in the previous presentation, what COVID and COVID isolation has done to many people, because we were forced to be in our homes for a long time, and we didn't mix with people, we did not have social engagements, and it caused people to become very, very isolated. And as we saw also presenting with depression in a lot of the elderly people, and of course younger people as well. One of the tips that Doctor also mentioned was avoid major changes in surroundings. Many of you have probably been in a situation where a person that has already shown memory difficulties, cognitive impairment, or we suspect that grandma or grandpa already has got dementia, something happens, they need to be admitted to hospital, and they become severely confused in hospital. Again, it's because of that change in surroundings. It's not familiar to them. Again, one of the problems here is that, as we know, the person can't learn new memories. Their older memory, their past memory is much better than their recent memory, and they can't remember things that happened yesterday, the day before, a couple of weeks ago, and of course even a couple of months ago. Another important tip in the management of people with dementia and cognitive impairment is we must be able to look at their behavior and understand their behavior. We need to understand what triggers the difficult or the challenging behavior. And there is a tool out there called the ABC chart, which allows us to capture and record, of course, starting with observation, and then jotting down what are the causes of the challenging behavior. So looking at the, I can never pronounce that particular word, antecedent, the behavior, and then of course the consequences. Another important pointer, and again, I've put that first because of its importance. If a person is not healthy and they've got severe nutritional deficits, it would make no sense for us to try and do some of the other treatment modalities and the sensory stimulation programs, for example, that we'll share ideas with you about if the person is not in a healthy condition. Dr. Kutzer mentioned the Mediterranean diet, and of course, another very important thing is the person having adequate fluid intake in a day. Most people don't realize that one should take between 1 liter and maybe 1.5 liters of water over and above your coffee and your teas and your other fluids that could be fluids that actually take water out of the body. And again, that also has to be determined based on the person's particular physical health and whether they have a heart condition or not, or whether they suffer from lung conditions. So the particular need for that patient in terms of fluid intake has to be determined, usually in conjunction with the doctor's prescriptions and the patient's chronic condition. Again, if one hasn't slept properly, how on earth can you face the day? So we got to try and help our patient with MCI or dementia to have a good night's sleep. And again, suggestions there is, if the person's had proper exercise or some exercise in the day, they might be physically more tired. One can do the age-old tricks like a cup of tea, a warm Milo, a bit of warm milk, make sure that the person's got a calm night routine, and perhaps even leave lights on if there's, for example, fear and anxiety when the darkness comes, which is something that we observe with our patients. Physical exercises, as we said before, are so important because the brain needs oxygen. In order for the brain to stay healthy and not become demented, one needs the oxygen, and even a 20-minute walk per day and some stretching exercises could be adequate to provide the oxygen that the brain needs on a daily basis. Physical checkup with the patient's general practitioner is absolutely vital. Your blood pressure checks to make sure that the patient is not perhaps on a stroke risk, your vitamin Bs, your vitamin Ds, your thyroid, your liver, your kidney tests, which is the basic blood test that your general practitioner will do perhaps on an annual basis, where it's indicated based on the history that the general practitioner will take, because all of these tests, if there's deficiencies in the body of your vitamin B, of your vitamin D, the thyroid is not functioning properly, even the thyroid medication that the person is taking is not at the right level, all of this will have an impact on the brain and can impact the level of confusion, the delirium that Dr. Kutzer also alerted us to and reminded us about. And again, in conjunction with your general practitioner or the specialist, if the person's under the care of a specialist, is so important that chronic disease is managed. Your diabetes, your asthma conditions, or your lung conditions, any of the chronic conditions has to be managed to the optimum. Because again, if these are neglected, it will have an impact on the brain function. And lastly, of course, the acute conditions, like we said, if the person has an infection in the bladder or in the chest, for example, that can cause acute delirium, which is reversible, as opposed to, as we know, dementia that can't be reversed. But it's so important then, of course, to look out for those conditions, and if the person suffers from them, to get them treated as soon as possible with, for example, certain antibiotics. In terms of mental health, again, if we want to care for our patient with MCI or with dementia, it's very important that we understand the diagnosis and the stage of the disease. If the person is in the early stages, it's hugely important that we make use of sensory stimulation. And of course, if the person is in the later stage of the dementia, we may actually just go for palliative care. Treatment of depression and anxiety, again, something that Dr. Kutzer touched on, which is vitally important in order for the person to have quality of life. If the person is sad and tearful and suffers from a clinical depression and or severe anxiety, the person can't have quality of life. And therefore, it's important that those are addressed. The person perhaps consults the correct specialist for this to be addressed and treated. Psychological difficulties, another important aspect. So again, depression, anxiety, fear. In many of the patients that we assess in the community to determine whether the person perhaps is showing signs of developing dementia and or MCI, we often see they often have a sense that something is wrong, but they don't know actually what. And then there's often denial. There's nothing wrong with me. I'm fine. Loss and grief, often of a spouse, and things like an anniversary reaction. So the actual annual date where the person suffered severe trauma in the past has a large impact on the person's psychological health, or difficulty, or what they struggle with, that brings on tearfulness and depression. And the role of a psychologist here can be extremely important. Some people can say, so how can a psychologist help a person that in fact has got dementia or mild cognitive impairment? There are some psychologists in the community that again has a special interest and specializes in the treatment and the support and the counseling of patients with MCI and or even early stages of dementia. They can help a person vastly deal with things like loss and grief, guilt feelings, anniversary reactions, and often that must be done in conjunction with the correct medication, of course. Generally about medication, just a quick comment. So I'm sure as you all know, it's extremely important that medication is always given as per doctor's orders. It has to be recorded and reported. The effects and the side effects of medication, especially if it's new medication, has to be reported back to the practitioner and the specialist, the general practitioner. Because if the person shows not good effects, in other words, is not responding to the treatment, and there are perhaps negative side effects, the doctor can't fix it if it doesn't work, or if the patient or the family decides we are going to stop this particular medication. The doctor must be informed. The family should work with the doctor in conjunction with the doctor to say, how effective is this medication, and does it need to be reduced? Does it need to be changed? Does it need to be stopped? Again, Dr. Kutzer referred to some of the dangerous medications. I'm just sharing with you two drugs that, again, my colleague Janet and I see often in the community. A lot of the older people were treated with one of the older generation antidepressants. In fact, the first antidepressant that ever came onto the market was amitriptyline. And again, patients are still on this particular medication, and the research has shown that this can put patients at great risk for developing MCI and dementia. Another drug that we also see being used quite a lot is Risperdal and Rispelet. And again, one of the studies, or some of the studies that have been done, shows that this can be dangerous in the use in an older person because of the risk of cardiac interference and cardiac effect, and even death can occur. We often use the American Geriatric Society Beer's criteria for potentially inappropriate medication used in older adults, and the paper is the American Geriatric Society, a document from 2015, where this paper lists all this potentially inappropriate medications to be avoided in older adults. And you will recall, those of you who attended the previous webinar, that Dr. Kutzer also referred to this. In terms of then also looking after and taking care of your older person with these conditions that we're talking about, safety concerns. Often, some of them, they wander, they would like to walk, they just on the go all the time. And if the person is not in a safe environment, of course, they can get lost with all sorts of consequences, which I'm sure we don't even have to just discuss. We can just think what could happen if they get lost. What is the person's risk of falls? This is another big problem that we have and that we see. Supervision is necessary if the person is a falls risk. A caregiver, of course, can be put in place to assist with this problem. Biokinetic exercises can be put to great use because the strengthening of the core muscles with biokinetic exercises can greatly reduce the risk of falls in your older person with MCI and or dementia. Self-harm, persons with depression, of course, there can be a suicide risk. And again, we see this. Recently, very sadly, had a patient who asked me, how does one use, she had husband had a big gun, and she wanted to know where would one put the gun if you wanted to kill yourself. So despite the memory loss, the cognitive impairment, and again, perhaps in the early stages, the person knows something is wrong and they don't understand it. And they just feel very, very depressed or suppressed and don't understand their emotions, perhaps even can't express it. Of course, if the person takes incorrect medication, if they are responsible for their own medication, and perhaps blister packing of medication has not been introduced yet, or the medication is not supervised. If the person is forgetful and they use a stove, of course, there can be a risk of something like the stove can be left on that can cause a fire. Aggression, of course, is another big problem that can occur in patients with some of the types of the dementia. Very important that we distinguish between verbal and physical aggression, because again, that will determine also how we will manage and handle this particular condition, and again, whether there is a risk that others can be harmed. In terms of communication guidelines, so I said with courtesy from the Alzheimer's Association of South Africa, as some of this is very nicely set out on their website. Patience, patience, patience. This is not easy. Repetitive statements can be extremely challenging. If the person asks you for the 10th time, when are we going home? Or where's the son that is not coming to visit? Any of the questions, any of the thoughts in their minds, of course, we know can be repetitive and can be challenging for the person that is looking after them. Very important to make eye contact. The person has to be able to see you. Because of the perceptual disturbances that can occur, when the sound is behind them and they don't hear it, it can be very troublesome and it can be more scary and they can become more fearful. It is crucial that they have a fitting and a working hearing aid and that their dentures fit properly so that they can eat properly. And again, the hearing aid, deafness cuts them off from the world and excludes sounds and discussions and music, all of which is a huge part and a very important part of sensory stimulation that again is one of the tools that is said to that can slow down the development and the brain failure processes. Further, in terms of communication, appropriate touch can be extremely valuable. Use the person's name when you talk to them. You'll keep their attention that way much better, and you'll help them to remember who they are. And again, at the same time, equal voice, soft-spoken voice, and your body language. If your body language is threatening, maybe you're standing over them as opposed to going down, sitting on a chair, facing them eye to eye level, can be much better and will work much better in communicating with the patient. In terms of the touch, just to also, we understand that some people don't like touch. And again, one has to judge and just make sure, is this a person that appreciates that you hold their hand or that you rub their arm, that you rub cream on their body, and they enjoy that sensual and sensory stimulation when you work with them. Others might not. So of course, important to judge and understand. Very important also that perhaps it's important that you are close enough that they can see your lips move, they can see the movements of your hands so that it won't frighten them, and make sure that you perhaps elicit other noises that can distract the person. If it's possible, if you're trying to have a conversation or you're trying to interact with the patient, perhaps take them to a quieter room. Holding a person's hand, as I said before, sitting with your arm around him can show care. Some people don't like touch, and of course we will respect their choice in this particular approach. As I said before, also your voice, speak slowly, quietly, use a calm voice. Very important that we never shout or raise our voices. That can lead to anxiety, and then the person will not hear what you're trying to communicate. Try and be relaxed, smile so that the person doesn't perceive you as angry. Keep your sentences short so the person can remember what you are saying. Short questions, one at a time. Try and get the answer first before you go to a next question. It can be very, very confusing for the person whose cognitive functions aren't good anymore. Repeat yourself if necessary a few times. Speak slowly. Change your words if the person doesn't comprehend what you are saying. And even if a person doesn't seem to understand, the advice is to never use baby talk, and don't talk to the person as if he or she is a child. Remember the pictures that I showed you in the beginning. Yes, they may be forgetful, but inside they are still that person who was a professional or a mother or whatever their life consisted of before. And again, if you want to work with a person with dementia, it is very helpful and very effective if we know what the person did before. What did their life consist of? Who were they? Ask the family to share stuff like that with you so that you can use that in your communication with patients. And if you're the relative or the loved one, again, talk to them about maybe their career in the past, their loving attitude towards their family, the lovely food they made, those kind of things. You can use memory aids and writing instructions. You can use flashcards. You can even use things like cut out pictures of foodstuffs and a bed, sleeping, any pictures that you can find in magazines, for example. And you can make flashcards that you can then show to the patient and the person if you find that it's difficult to communicate with them and you can't get through and you don't understand what their needs are. So you can show them some of the cards, and at the same time, you can then ask the person to point towards the card that you are showing, and they can perhaps say to you, nay, a no, or yes, that is what they are, what their need is. A few more management tips. If the person is acutely confused or delirious, the delirium that we spoke about, the potential causes can be pain, they'd be uncomfortable, they can be starting to develop an infection, and of course it could be side effect of medication. Because this is so important and it is so often missed, it is crucial that we just keep that in mind when we are managing and caring for people that have got this particular problem. You can put a scrapbook together with photographs and pictures. This is an extremely useful tool. There are also like a printout on the internet that one obtain, and we use that quite a lot in our work, where we help the person to write a life story, which helps them remember who they are, what they did, and what the meaning of their life was. In this process, one stimulates a lot of recall and memory, expression of feelings, and of course speech when you ask them to describe and discuss the particular events. In our work, what we do with the carers that we place to look after people with this particular problem and take care of them on a daily basis, we train them so that they can understand the meaning of this and how to deal with some of the emotions that come up when the patient tells them about events from their past. Very important, laugh together. Please reassure the person that if they've dropped something and it broke, or they tripped over something in the corridor, or they missed some food or coffee, or even if they've wet themselves, reassurance is crucial, and for the person to understand that it is not a problem. It is okay. We have to, of course, have a lot of empathy with our patients and with people that suffer from this difficulties. And again, it's not easy. And as my previous slide said, patience, patience, patience. When the person deteriorates, of course, again, they may show signs of increased confusion, talk about things that are not true. My clothes are being stolen, my food are being stolen. They can even hoard food in a cupboard if they're living on their own still. And it's not always necessary to correct the person and say, why did you do this? Or please don't do this again in the future, because it's so important that we remember that if the short-term memory has been severely affected, they cannot make the new memories and they can't remember. So if the person's saying, my mother is coming to visit, but you know their mother is already passed on, rather than correcting them, but I've told you, they can't process that particular piece of information. So rather consider, why is the person saying that? They're probably longing for the loved one that they're talking about. And it would be very helpful if one then discusses with them and use the other skill of distraction and saying, tell me about him or her. What do you recall? What was it like the last time you saw him or her? And again, if we use the skill of empathy, putting yourself in the person's shoes, how difficult would that be if I was in their shoes? Just a few tips on aggressive behavior. Communication, again, very important. Calm, soft-spoken, eye contact. Take control of the situation. If you're either the loved one, the carer, the staff member in a facility, if you take charge and you feel calm, the person will most probably feel the same and feel reassured. Sensory control can be used. So you can use something like a weighted sensory blanket, a teddy bear, a weighted teddy bear to put on the person's lap while you're talking to them, whilst you're trying to get them to express what they're angry about, what they're upset about, what's going on in their mind. Some facilities in our community has got a calming sensory room, which is extremely useful method that can be used to assist people in expressing their feelings, their distressing feelings, especially. Soothing music obviously can be used and is sometimes used. Here, the role of a trained occupational therapist is extremely important. And like with your psychologists, not all occupational therapists necessarily has got the skill, the knowledge, and is not necessarily interested in that field. They may work with children and they might be experts in treating children with various difficulties, emotional problems, and so forth. Whereas in the occupational therapy field, there are some occupational therapists, again, that has got the interest and that particularly works with us. The use of medication, careful and safely, again, as pointed out wonderfully by Dr. Kutzer, it has to be, of course, always prescribed by a medical practitioner with the knowledge and the experience of what should be given to the person, what is the dose that should be given, because we do not want the patient to be zombie-like. Restraints can be used. It is a method, but again, it's only if it's done with permission from the family in writing on doctor's orders, if all other methods have failed. And it's done, again, in accordance with some of the philosophies behind it, maybe for a short period of time, 5 minutes, 10 minutes maybe, and it's done in a way to assist the patient in just calming down and perhaps getting some of the fear and the anxiety that they might be feeling at that particular point to get that under control. Lastly, in terms of the psychological health of the family members. So in many families that we work with and that that consult with us, we find that they are extremely burnt out. So in our counseling and our support, we try and help the family members deal with guilt feelings, depression, their own loss, and grieving the life of a loved one who is now so changed and has lost all their abilities. And they often remember this highly efficient father, mother, uncle, aunt, whoever it is, that were in a high position in the community and now has come to a point where they are having great difficulty in communicating and has lost a lot of their dignity. Sometimes and often there's denial, and especially some family members may realize there's a big problem here with our loved one, whereas other family members then can say, no, there's nothing wrong with dad, he's just a bit forgetful. And it's hard, really hard for some of the family members to face the reality and to understand the degree of perhaps the cognitive impairment and or the level of dementia that the person may be suffering from already. Of course, if there's financial constraints, there could be fighting and bickering in a family because of how on earth are we going to care for the loved one. Respite care, something again that Dr. Kutzer mentioned, is extremely important. It's a 2-week period or a 3-week or a 4-week period, of course, depending on the resources in that particular community and in terms of the family's resources, but it's something that should be considered, because again, that can be hugely helpful for family members that are already burnt out or that are becoming burnt out. In terms of the decision for care at home versus placement in a facility, actually a topic on its own that we could probably have a whole hour's presentation on. How do we decide? What would be best for the person? Would it be better if they're in an environment where there is a lot of social stimulation, because this person used to be very social, very outgoing, and loved talking to other people? Or is this person somebody that maybe the family would like the person to be with them until the day that they die? And again, one can look at the pros and the cons of both of those options, and then the family can come to an informed decision about what would be best for their loved one and what would be best for them. There, of course, are some, not enough, not nearly enough in our community, support groups, which maybe you can join, where you'll get some support, knowing that you're not the only person or the only family that is going through this trauma, because a person being diagnosed with either MCI or dementia is very, very traumatic. So just quickly to end off with, I just want to share with you some ideas about sensory stimulation. Again, sensory stimulation is a topic that I think we could probably have at least an hour webinar on, or a seminar on. And just for interest's sake, to share with you a little picture, giving you an idea of where some of our senses are situated in the brain. And as the slide shows, you can see in the yellow portion, there's the touch and the taste sense that we possess is in that portion of the brain. In the frontal part of the brain is the smell, the hearing is like mid-center of the brain, and the vision is in the back part of the brain. Sensory stimulation. So what is this? Of course, it relates to the senses of our body, and it's a stimulation action that raises levels of awareness within us about the different senses we have: vision, hearing, taste, smell, and touch. And perhaps one of the senses that many people don't know about is the position of our joints, where there's special centers that provides awareness of where we are in space, where our body is, and how it is positioned. And it's called proprioception. So if you sit on a chair and somebody pushes you very hard and you're a healthy person, you will obviously be able to stabilize yourself and not fall off the chair. Whereas a person with cognitive impairment and or dementia in one of the stages may in fact fall over when we push them, because their proprioception sense is no longer as good as it should be. Movement. In our ears, of course, we have a special mechanism, our vestibular system, that provides awareness of the movement of our body, the speed and the direction we are moving. And we know that if the vestibular system becomes impaired, we have difficulty with movement, and our balance and our gait might be severely affected. What is the purposes of senses in our body? Well, it enables us to learn and understand. It gives us protection because we can balance ourselves when somebody pushes us. And of course, the enjoyment that we get from all our senses, which in the end provides quality of life, which again, just brings me back to how important it is that the person's vision and the hearing, for example, is tested regularly and ensured that the person gets the right pair of glasses and or the right hearing aid that fits well, and that we sometimes with great difficulty get the person to wear the hearing aids because of the consequences if they don't have good hearing and good eyesight and so forth. Of course, without sensory abilities, the person becomes more and more isolated. They can even have fear. There's tolerance changes, and the world shrinks for them to a vast amount. So some of the tools that one can use, and I'm going to just briefly refer to these, like your own body, your own voice, your own hands, compassion and control of your own emotions in dealing with people with these conditions is vital. Move slower through nature, use the environment, and suck up what is around us. And again, we even train our carers very much to use this when they look after patients with these conditions. Know the person so that you can understand, what did they like before? What music did they like? What did they enjoy? Walks in the garden, smelling the mint in the garden, smelling the flowers in the garden can be very useful. The past memories, as we said, with the life story, music, self-care, where there's smells, textures, and touch, rubbing cream into the person's body, exercising, stretching and walking, vital, as we saw. And in terms of communication, as we said, a lot of eye contact, words, touch, position of your own body. I want to hand over to my colleague who's going to just give us a few more practical suggestions in terms of cognitive stimulation, because again, there's lots of tools out there, and the purpose for us presenting is again just to help you understand that the person who suffers from these conditions can be assisted largely perhaps to experience some quality of life. Okay, Jan, over to you. Oh, my apology.
Good morning, everybody. Well, as Emmy said, it depends on, as it was alluded to previously, that there's a continuum, and depending on where you are in the continuum, and there's no real strict idea. It goes from mild cognitive impairment and then all the way to severe impairment. So we're needing to look at that to see what type of stimulation would benefit the person. So a few examples of the things that we would use is a
yes, please,
is a fiddle, what's known as a fiddle blanket, and this helps with when a person has dementia. They often fidget, and this is they don't know what to do with their hands, and often fidgeting could mean a lot of things,
so this is just an example of a fidget blanket where there, for example, is keys that makes a noise, but that can have a meaning. there's a small little car here, there's a little house sewed onto, there's a bird, there's materials that can be used in terms of, again, sensory stimulation of the skin and the feel of the particular textures on the document. Another thing that we refer to, for example, is just a teddy, which has got a weight in it, and is then again, it's a weighted teddy, which often helps with calming. Thanks, Janet, really appreciate. And just for me to finish off in terms of my last slide. So this is a very difficult journey. It's complex. It can be a very painful one. We hope to be able, that we've shown you a little bit of how you can learn and grow and make your own life a bit meaningful when it's so hard caring for a person with these particular conditions. And just remember, one of the sayings is, I won't necessarily remember what you did for me, but I will remember how you make me feel, based on some research that they've done in the UK. So the memory's gone, but when the way I treated you will make me remember, will help the person remember how we made them feel. Thank you very much, Minda. I think that's quite a lot from me. If there's any questions, happy to answer some questions.
So we have received some questions. I just want to first congratulate you on your input. It was well formulated and well thought through. Thank you so much. And one of the questions was, in what way can we prevent a person suffering from dementia from isolating themselves socially? I would imagine that would be in the earlier stages when they just start isolating themselves from others.
Yeah. So obviously, in the ideal world, the person engages with their family on a daily basis. Or, of course, you can place a caregiver with the person that has got some skills in doing activities with the patients, perhaps even taking the person across to a friend that lives close by to enjoy any activity from drinking tea to playing a game with a person like that. Or, of course, if you place the person in a facility where they can actually interact under supervision and participate in a program that is perhaps offered by a facility. Again, in our country, there's a huge need, and some of this is done in other countries where there are daycare programs. So the loved one is taken to the daycare facility where there is a program starting with or without breakfast perhaps. After that, there is perhaps an exercise program that is done by a physio where everybody does stretching exercises, some passive exercises. After that, maybe there's again a cup of tea together. After that, there's some cognitive activities that are done where, depending again on the level of your group, patients and the residents or the participants are encouraged to do things like, so what do we call the person that fixes the water pipes and the toilet when it breaks? Okay, so that's the plumber. So maybe you have a little exercise that asks questions like that. And again, the presenter then uses that in a way that stimulates everybody's memory, but also you can make fun of it and let them have enjoyment and fun. And then again, you can have throughout the day, you can have activities that suits the needs and the level of that particular group.
As you mentioned, families and people's needs differ, and they come to a stage where they're burnt out and they are looking for a carer or a caregiver or a place where they can put their loved one. Getting to the carer or the caretaker or the nursing assistant, what are the qualities that one should look for, and as well as the qualifications that they should have?
So nursing assistants, of course, are the least qualified of your registered nursing personnel in the country. Your nursing assistants and higher levels, up to, for example, myself and Janet, that are registered nurses, is registered with the South African Nursing Council, whereas carers, registered carers, they are registered as healthcare workers, are registered with the health CETA in this country. They do a basic sort of 3-month, some 6 months training through some of the facilities that are registered with the health CETA, where they are taught basic caring skills like how to feed a person. So that, for example, you don't put a spoon from the top, but you feed the person from the bottom. They taught skills like that. They taught how to bath a person, how to do a bed bath, basic tasks like that. And then most of them continue to gain experience when they work at retirement facilities, and they kind of, I think it's a bit of an in-service training that they get to work with patients with dementia and or Alzheimer's and you know, other forms of dementia. There is Alzheimer's Association also presents a 5-day course, usually a couple of times per year. I think some of that, of course, they weren't able to do it through COVID as much. I think they're back on track, and they do a 5-day course where they take your carers that are registered healthcare workers through the CETA in order to provide them with a specialized skill in terms of caring for a person with dementia and or cognitive impairment, and specifically also the elderly, of course. And then there's various agencies out there that employ carers and that places carers. Again, in our country, because of the cost of your healthcare, this type of person's care and service and service that they can provide has become quite popular, yeah, and it's used widely.
Thank you. Another question was whether it's unusual for a person suffering from dementia to, at some stage, stop communicating. And does it mean that they're not feeling well, or is it sort of, well, normal in abnormal situation?
So the tricky part is to try and determine why. Is the person different from the way they were yesterday and last week? So in other words, is there symptoms that we can determine and that we can pick up and say there is an infection brooding, and that's why the person is so apathetic and don't want to talk, and they're completely disinterested in the world around them? We can test their urine, for example. Or is this a pattern that we've been seeing that's come over the last couple of months? Okay. So again, we will look at, is it acute, or is it come over a period of time? And again, you need to look at the particular circumstances and then say, is it unfortunately just part of the deterioration? Is it the stage that we've reached? Or is it something that we can try and address with things like, let's just make sure that there isn't an infection. Is the person become sad? Depression and dementia often goes hand in hand. And people don't realize how often it actually presents in a person with dementia. And if they put on the correct dose of the right antidepressant, very, very small dose, the person can be so much better. But again, the person can be bored, the person can be lonely. So again, one need to look at the circumstances and say, how can we help? Hope that helps.
So from what you're saying, it means that if it has an acute onset, it probably means that there's something that can be changed, or a medical condition that needs to be addressed. While if it's gradual onset over a period of time, it's probably part of the illness. Am I correct?
Indeed. Okay. Yeah.
Okay.
That's the generalization, of course. But it would be helpful if one looked at the detail and say, did something happen? Was there, was there an event? Was there something that happened a few days ago, which is causing the picture that we are seeing at the moment?
Okay. So sort of similar to that is a question about the loved one sleeping an awful lot, not wanting to wake up, not wanting to get up, and how do you handle that?
Okay, so we know that a person with dementia, the brain is failing, so they need more rest. Even if we put in place a very structured, a daily program, which is very much needed for every person, to help also prevent them just lying and sleeping all day and sitting in a chair and sleeping all day. The best way to prevent that is to have a program in place and just have a routine. So now we get up and we bath, then we have breakfast, then there is somebody that does that particular activity with the person. Then afterwards we have a cup of tea and the person is allowed to sleep in the chair for maybe 10 or 15 minutes or half an hour. Then after that we do another activity. We go on a walk, or maybe the walk is earlier in the morning because otherwise middle of the day, of course, it's too hot to walk. If it's in a facility, of course, it can be down the corridor. So the daily routine and structured program is one of the most important things to manage and prevent this kind of thing. But allow physical activity so that the person's body will become tired, but brings oxygen to the brain, which will help with the sleepiness and will help with this tiredness and just wanting to lie down all the time. Yeah, if the person still understands, if they can still comprehend, one's got to talk to them a lot and say, come along, we are now going for a walk. It is important. You have, I don't want to do this. No, come on, we are going to do the walk. You are going to enjoy it. You know, those kind of approaches is not always easy, but very important.
So I wonder if I can just ask one last question, and that's, or maybe just make a comment. There was a question about social groups for people actually suffering from the dementia, not only support groups for the family members. And it seems like, I think we spoke earlier the weekend that you said there's actually a need for that. Yes. And that us as facilities must look into the possibility of creating such accommodation, such facilities. Yeah. Well, I think we're running out of time. So thank you once again so much. And I would like to repeat that this talk will also be available on Ekklesia Park's YouTube channel, and that you can find the link for it on our website. Hope to see you soon, Sister Emmy, Sister Janet. Thank you so much for presenting today.
May I just say, I spotted some questions in the chat which maybe weren't answered. For example, is there a facility in X area in the country? So I trust that maybe you will let our details be available to people should they want to consult with us, and we can give them guidance and we can point them to other professionals that can help. You know,
we will definitely do that.
Right.
We can.
Thank you, Minda.
Thank
you very much for the opportunity. Have a lovely day, everyone.
You too. Bye-bye.
Bye. Thank you. Thanks, Amin. So much for all this